I am pleased again to introduce I believe it's the 21st Carl Martinson Lecture. This is an endowed lecture devoted to interest in ideas of health promotion and disease prevention, topics which were central to Dr. Martinson's beliefs and clinical practice. Dr. Martinson was born in 1888, his Swedish immigrant parents. He graduated from Union College in Omaha, Nebraska in 1913 and taught chemistry at high school and college level for 3 years. And while teaching in Chicago, he met John Harvey Kellogg of Battle Creek, Michigan, who was also a physician and a cornflake guy, who encouraged him to enter medicine. And in 1925, he graduated from Loma Linda Medical School in California and did an internship at LA County Hospital in LA and entered the practice of medicine and surgery in Wayzata, Minnesota in 1927, where he founded the Martinson Clinic and the Minnetonka Hospital. If you saw the pictures from 1928 that we see there, they did surgery and other things in the clinic, and Tom Martinson was telling me it was his grandmother, Carl Martinson's wife, who gave the anesthetic while he did the surgery. I assume dropping chloroform on a mask on the patient's face. Things were basic there and probably worked very well. But the characteristics of his career go beyond dates and his practice. His clinic long stressed good health habits as a means of preventing disease. Remember, this is in the late 1920s. It was an important lesson then, as it is today. From the beginning, as I say, the Martinson Clinic was smoke-free from 1927. It took University Hospital until 1985 to become smoke-free. So they had some ideas then that clearly smoking was not good for you. We're fortunate to have Dr. Martinson's grandson, Tom, and his wife, Joan, here representing the family and the foundation, and I welcome them. So today, we're fortunate to have Dean Marcia Davis from the University of Georgia College of Public Health. Dr. Davis is a graduate of Duke University, Columbia Teachers College, where she has a master's in education, and the University of Minnesota, where she received her PhD, did a postdoc, and served on the faculty. I might say when I shared this with her, I didn't clear it, I just confirmed it. High point of Marcia's career, of course, is she sang backup for Bruce Springsteen. We will not ask her to sing. When she was at the U here, she worked in the Minnesota Heart Health Program and Catch and the 5-a-day program. And actually the only article that David Murray and I had from our 10 years work in Moscow for the US-Soviet treaty was an article on kids smoking that Marcia published. So she was busy here, but she left Minnesota for Emory and the Rollins School of Public Health and was there many years. But most recently, for the last 12 or 14 years, she's been at the University of Georgia, where she initially was Associate Dean for Outreach and Engagement, and has run for 12 years an annual public health conference and a public health leadership academy. She's been funded by the NIH, by the CDC, by the Department of Agriculture, as well as the state, doing projects that confront rural health problems in Georgia, a substantial issue. She has won multiple awards for teaching, for service, and for her research. So I want to welcome Dr. Davis and look forward to her discussion about her work in community-based research in rural Georgia. Welcome.
Thank you, Dr. Locker. I'm very grateful for the invitation to speak and to the Martinson family for their support. Everything I learned about community-based research, I learned here from faculty and staff. Some of them are here, so it's a privilege to be back to what I'll always call my academic home. Today, I want to talk about the personal and institutional context of doing community-based research in Georgia, talk about the whys and hows of it, and then give some examples of our work at the university. So just as we think about the social ecological model for community interventions, I think it's important to look at the individuals who are conducting community-based research, the institution, and the societal context. So my family roots are in North Carolina. This is a photo of my great-grandparents. The little girl in the middle who's barefoot is my grandmother. There was 10 to 12 years between my grandmother and my great-aunt. My great-grandmother was pregnant at the age of 50 in 1899. They were preparing for her death, but that didn't happen. They had 12 children. Twins died from diphtheria, and one had polio. My grandparents settled in Siler City, North Carolina. I stayed with my grandparents most of the time, doing what you did in the rural South in the 1960s. We were farm to table before it was a thing. And my grandfather worked at a furniture factory. The only time he saw a doctor was when he cut off a couple of fingers at work. My grandmother stayed at home and really raised me. And apparently I was a handful. But she instilled in me, as well as those around me, to go to college. And so through full scholarships, through the NIH training grant, through people who took a chance on me, I am here today. I owe my career to those people. And then for a brief lapse of judgment, I decided it would be fun to be a dean in Georgia during a global pandemic. But I'll save those reflections for another day. So let me tell you a little bit about the University of Georgia besides its football team. So UGA became a land-grant institution in 1872 under the Morrill Act. So this formalized the university's mandate for the state cities to benefit the state citizens. So we have an obligation to extend these resources to communities across Georgia. So the tripartite mission, growing teaching, experiential learning, growing research and innovation, and strengthening initiatives in Georgia and around the world. There are 18 colleges and schools at the University of Georgia. And the reason I put them up is that interdisciplinary work and team science is very valued by the university. They provide interdisciplinary grants, trainings on team science, and later on in the presentation, you'll see all the ones that we partner with in the College of Public Health. We have a public service and outreach unit at UGA. Cooperative extension, Archway partnership. I'll go into a little more detail about those later. But this helps communities across the state with locally identified challenges. Carl Vinson Institute of Government educates government officials throughout the state. The College of Public Health participates in that training to make them aware of how much public health influences the health of the state of Georgia, also with economic development. The Fanning Institute provides leadership training to communities, youth, and nonprofits. We offer continuing education programs, and we launch the small business launches and grows businesses across 18 regional offices in Georgia. You're probably familiar with cooperative extension that does exist in land-grant universities. This was the Smith-Lever Act of 1914 that codified into federal law and provided funding for outreach endeavors at land grant. So it was an interesting funding mechanism that the money goes from Congress to USDA to land grant universities, and state and counties also put in funding for this. We have a presence in all 159 counties in Georgia at this time. The Archway Partnership is an extension of extension. Extension has certain mandates related to family and consumer sciences, nutrition education, agriculture. But Archway Partnership was formed to bring all of the resources of the university to counties. We had at one time 8 counties, but then counties graduate, but they all become a part of a learning community with lessons learned in those communities. When we ask about locally identified priorities, health always comes up. So public health has been a key factor in all of these communities. There's an Archway professional which lives in the community and serves as a neutral party into bringing resources of the university to those communities. They're very active in funding graduate assistantships and faculty research. So in terms of, I have a school-based research project, and it was so easy to come into the community because the principal is on the executive committee, and the schools were engaged in that research, and it just made it facilitated that research very well. We also need to acknowledge football, though. With all due respect to the rest of the university system of Georgia and other schools of public health in the state, just as the U is beloved across Minnesota, Georgia is the bulldog, spelled D-A-W-G, nation. And wherever you go in the state, you'll see ceramic bulldogs there. They'll ask about the football team, so faculty need to be a little educated on Brock Bowers and his injury, and will he return? I never thought I would be doing that, but that's important culturally to know. This is Boom. He's our new puppy. But he has a little air-conditioned house during football games and is treated very well. But it's interesting throughout the state because most people that you're meeting will not go to the university, but they value the university. And it's humbling to say, I'll fill out this questionnaire for you because I want UGA to be the best. So it's a great responsibility. But it builds trust and a willingness to partner. So in this context, as the College of Public Health, we are on the Health Sciences campus. There is a medical partnership with Augusta University. We do not have a medical school yet, but we share this campus. And why public health is so important in Georgia. If you look at the map, the latest one from the county rankings, you'll see the metro area of Georgia is okay with health. But if you look at outside of the metro area, the health outcomes are not good. And this is because of access to care, social economic factors, the social determinants of health also mirror this map. So our mission, like most missions of colleges of public health, we want to improve the health of all. Our values are embedded in diversity and respecting diversity of all forms, engagement to have meaningful partnership with communities, and equity so that equity will drive access to research, education, and continually improving diverse populations. We value experiential learning, so several of our courses, going back again to the units within public service and outreach. We have a lot of service learning classes, getting students engaged in teamwork, which is what public health is, and to have them be able to go beyond knowledge, to look at skills that you will need in working with public health in real world situations. This picture is an example of students taking samples of wastewater when we did surveillance for COVID. Research and external funding, we had $22 million last year in external funding. When I became dean, we started forming research working groups around topics of interest, such as climate change, health equity, disaster preparedness, and a strong emphasis on innovation. And I'll show you some of that from our care center. The focus is on meaningful research that has an impact on the health of those living in Georgia. We do have an Institute of Global Health that does work with tuberculosis in Uganda. But the lessons there are the same that we're facing in rural Georgia. So as Bill Fahey said, global is local and local is global. Our outreach, engagement, and equity unit, an equity part, as Dr. Lupker said, I started the State of the Public Health Conference. We just had our 12th annual. I can't believe it's been 12 years for that. But we bring together on average around 300 people a year from state, district, and local public health, as well as nonprofits, other academic students, to really have an honest dialogue about the health issues in Georgia and how best to deal with them. We have the Health Equity Hub within this office where we have Health Equity Fellows, which is a partnership with the Georgia Municipal Association. And we also have from foundation money to fund students to be in communities to address equity in those communities. We have a social determinants of health certificate as well. The Public Health Leadership Academy is funded by Georgia Power, and we bring together different sectors of the community to provide training on how to build a culture of health. So it could be bankers or school superintendents or teachers. It doesn't have to be necessarily the public health workers in the community, although they come. But the idea is, again, this multi-sector approach for public health. We partnered with one of the Archway communities, did a needs assessment in that community. And for the work that we did, we prevented a rural hospital from closing. And as such, won economic development award for that. And finally, along with the social work, we designed a rural engagement faculty workshop which brings together faculty from all the colleges at UGA and trains them on working in rural communities. And upon completion of that, they get a seed grant that allows them to conduct a project in the community. So again, I'm preaching to the community choir here, but why do we do community-based research? We have to engage communities if we want to improve health. Being able to tailor interventions to communities and their needs are very important. We can also address social determinants of health through engaging with communities. We can be advocates for policy change, and we don't want to leave a community without having the sustainability. So the concept of parachuting into a community is the wrong way to go about it. You can put a face on all these the people coming down and saying, oh, we've got a great idea. We want to work in your community. You're going to want us. So we're just going to come down and serve you. And that is not going to work in the community. And so for this, we have to think about how we engage communities. And one of the first ones is the communication, to be very clear about why you're there, what you expect of them, but also to get to know the community. What is their relationship with the university, with other projects that have happened there, and be a part of the community. Go to local restaurants. Show your interest in learning about them. And it takes time and it's hard work, but you must respect the members of the community and what they have to offer. Engaging all these populations will allow you to tailor interventions to a community that's going to be receptive to the interventions. Community collaboration is very important. And we can talk about the power dynamics from a university to a community and kind of breaking those down. So I want to talk a little bit now with that as a backdrop of work that I'm doing in the university. So Healthier Together started in 2016. This is funding from CDC specifically for land-grant universities to work with extension for policy systems and environmental changes in the state. So the first round of funding, CDC designated 2 counties. So I just got through saying that we have a presence in 159 counties, and we do now, but in 2016, of all the luck, one of those 2 counties did not have an extension presence. And there was a reason for that. The community really didn't want to have a relationship with the university. So this was a tough battle. In fact, there was the first coalition meeting, which I was so excited to be at, and a coalition member turned to me, pointed his finger and said, how much is it costing me for you to be here? Because there was a publication that came out from the University of Georgia, so excited about this funding that they said the 2 counties and $500,000. So he was wanting a check for his $250,000. And so explaining to him that the money came to the University of Georgia to bring expertise to his community and provide money for these projects, that took a long time. But then he became one of our biggest advocates. But the top-down approach. But then we got a renewal of this, and again, CDC designated more counties. And then in this last funding, which we just got, we got to pick the communities. So we divided up the communities into existing communities, those that the engaged, the emerging counties, which we feel have the infrastructure, the community members willing to participate, and then those counties that we're assessing where they are in this process. So again, it's going to be work to pull the counties together. Our mission for the project is to do policy systems and environmental changes. But again, CDC was really, even though they're based in Georgia, they didn't really know the counties we were working in. So they said, well, why don't you work with the grocery stores in the area to pull them together for purchasing power? Great idea, but there are no grocery stores. So that their idea, we couldn't, so we have to work to say, well, what can we do if there are no grocery stores, where there are no sidewalks to walk to stores, where school could be 10 miles away. So we have worked with the coalitions to find ideas that we could do to engage the community members, but also to look at interventions that would affect policy, but in a small p policy rather than the statewide policies. We wanted CDC to help us with Dollar General, because Dollar Generals are the grocery stores in the area. And I'm not sure all the politics of that, but we're still waiting on that partnership. We can do some things in Dollar General to help with shelving and those sort of environmental changes. But over time, we hope that the interventions will lead to healthier eating, more physical activity, and then well-being and a sense of equity in the communities, because everyone will have access. So the community coalitions, again, very broad membership in the coalitions. The extension agents work with the coalition to get health needs assessment, data, equity assessments. They then provide the data to the coalition and look for resources within the community. So when you think about the poverty in rural communities, there are also really great resources. One of our counties has a state park. There are pockets of resources in these poor resource communities that we can build on. So we use a strength-based approach for that. We work for partnerships. So if we have someone in the community who can pour cement, then that's their volunteer, and we can make parks and basketball courts and things like that for the community. The nutrition strategies have been focused largely on food pantries and providing food, the nutrition for healthy foods in food pantries, retail food outlets to the extent that we can promote fruits and vegetables in those, providing coolers for fruits and vegetables in restaurants or drugstores where people can get food that way. We're looking at food and vegetable voucher incentive programs and working with physicians for prescription programs, but there are very few physicians in the area. So we're going to have to work with other people with that. For physical activity, it's really making destination routes. So if we could connect downtowns that they could walk from the drugstore to the public health office. So we're trying to do that with the communities, parks, walking trails. Our evaluation is This is not considered a research project by the CDC. So our evaluations are really focused on short-term evaluations with looking at environmental scans for access to healthier foods, policies that work sites might have done, for example, to promote physical activity during the workday, and then changes for supports. This funding was new in that we were asked to look at family health weight programs. That was a new addition to this call for proposals. So we have worked here since 2016. So we are looking now at intermediate outcomes of purchasing and distribution of healthier foods and increased places for physical activity, and then access to family health weight programs. Long-term, we hope to see improved health behaviors and outcomes. We're collecting that data on a yearly basis, and then reduced health disparities, and bringing the community together so that everyone will have access to the destinations for physical activity and for the fruits and vegetables. So the lessons learned is more work needs to be done when you're given a top-down approach from the CDC. We did not get on top of the narrative that was being told to the community. So that's where, there was a lot of repair work on, where's my $250,000 here and what are you doing with that? Just working individually with people to try to explain the grant process, which, only my children know from being with me when I was submitting grants. They know what's going on. But, for people who have another life that is not around grants and their funding cycle, it's harder to explain, but it's important to talk through that. To have an honest dialogue, both with the funder and the community, with what you're able to do. They're, again, explaining, what's an allowable expense and what's not, and, can we deer are in our community garden. Can we buy a fence for the deer? Well, yes, you can. But other things, it was no, that's not allowable. Also be prepared to bring other resources to the community. So in getting to know our participants, we found that some were unhoused and living in their cars. So how can you talk about any physical activity or eating fruits and vegetables when their basic needs are housing? And so when we found that the children, particularly during COVID, were not going to school and not getting food, we had to find a way to get food to them, not a part of our grant, but again, part of our mission at the university to serve people. So that was working that into the project of what can we do about housing in rural Georgia. So another project that I want to talk about is the CARE Center, the Cognitive Aging Research and Education Center. I'm the evaluator on this. I'm not an expert in aging except for myself. Alzheimer's and related dementias are prevalent all across Georgia, and I'm sure if I were to ask a show of hands of how many people have someone they know or caring for someone with dementia or Alzheimer's, I bet everyone here would raise their hands. The issue in Georgia, again, we're 159 counties, but there are rural health disparities. We don't have practicing physicians. So we started the CARE Center to address this. knowledge, cultural infrastructure, and economic barriers prevent access to diagnosis and interventions. So let's start with the knowledge barriers. I would hear growing up Alzheimer's disease. And so I thought, well, that's just people not understanding Alzheimer's and the pronunciation of that. But no, it's Alzheimer's. Old people are going to get this. So it implies when you get old, you must get demented. This misconception is a problem because in Georgia, we don't understand what is normal memory change and what's not. So in fact, 80% of people in Georgia who experience cognitive deficits have not discussed that loss with a healthcare provider. Low health literacy and mistrust in science are prevalent in rural communities. And all of these leads to barriers for diagnosis and to seeking help. There's also an infrastructure problem. Approximately 20% of Americans live in rural communities, but only 8% of specialty physicians practice in rural communities. And that creates a physical barrier to diagnosis. To complicate matters, rural healthcare systems often lack the neuroimaging equipment, cognitive testing tools, and advanced laboratory facilities needed to diagnose and to treat. This only adds to additional medical expenses. So in summary, the knowledge, cultural infrastructure, and economic barriers partly explain why rural communities with different lifestyles, healthcare access, and knowledge tend not to have access to education, diagnosis, and post-diagnosis support. So to address these challenges, we formed the Care Center. And its mission is to provide a new pathway to living with dementia. So together with our partners, we have worked with Archway Partnership, with Extension to forge a new way of thinking about cognitive aging in the state. For so many, when you receive the diagnosis of dementia, it is earth-shattering. And emotions are overwhelmed with how am I going to live with this? How am I going to care for my loved one? So we hear over and over frustration and hopelessness that people feel when they're handed this diagnosis. And doctors will say, I'll see you in 6 months. If they can find a way to a doctor, if they're lucky enough to be able to get to that doctor. People are living longer than ever before with dementia, on average 10 to 12 years. This is a significant chunk of life. So our team focuses on living with dementia. So in each of the areas, here are our community partners. In education, we work with Extension. For community engagement, we're with the Archway Partnership. And for health education, online learning, that expertise comes from the College of Public Health. The diagnosis, our medical director is a gerontologist with the Augusta Medical Partnership. We have neuropsychologists in the College of Public Health and psychology and neuropsychology in the Franklin College of Arts and Sciences. We have speech pathology and hearing with that expertise from Mary Frances Early College of Education. In the support arm, social services is through the College of Public Health. We have a joint MPH MSW and place our capstone projects and internships of those students. For law and veterans legal expert, we partner with the School of Law, and clinical pharmacy is through the College of Pharmacy. The Care Center is a fully functional geriatric specialty clinic. staffed with medical examination space tailored for geriatric patients, a neuropsychological assessment suite, an audiology clinic, an optometry clinic, space for drawing and handling human specimens, including blood, saliva, and urine, and it contains translational research space to design and test products that can help older adults in place. The care clinic sees patients free of charge because it's first and foremost a training center. Trainees are social work interns, public health interns from all departments, medical residents, medical students, clinical psychology students, clinical neuropsychology interns and externs, pharmacy residents, and academic students from 15 different departments. I like to go to the clinic. I try not to speak too much in case they catch any dementia in me. But it's a lively place with students. There are a lot of tears that can be had, but it's a very supportive place. And I mentioned doing the translational research. We're testing out robots to help with looking to, it's like I don't know, a scooter that kind of follows the patient around. You can test the strides in walking, test their speaking through the robot. We also have piano robot that is teaching older adults how to play the piano, providing them with a keyboard. And then what we can do is test this before we put it out in the community. So here we are where we are now with the state. We have these communities that we're working on, but we also have a waiting list. But it's part of our strategic mission of the college to engage more communities. So right now we're primarily in Archway communities, again, because of that facilitation and helping us engage with that community. But much of the work that's been done has been spent on the extensive groundwork that we need to do in collaborating with these communities. We chose 4 pilot communities that were based on our guidance with Extension and Arts in Partnership. But then we have spread out throughout the state. So how we do this is the first phase is listening and getting the people who need to be at the table. And this has been an interesting process when we talk about all the micro communities that exist even within a community. So we draw from faith-based organizations, from the community churches and schools. Then we go through an active planning stage with the community. So they decide what they want in the community. And then we implement that. And then our last phase is with evaluation. So what we have learned that communities want from an education point of view is health seminars, workplace health programming, educational handouts and other tools to give patients and their caregivers, to serve as a resource center for their questions and videos for their libraries and schools, educating them on dementia. We are setting up for diagnosis, telehealth in the communities. Again, the infrastructure we're trying to work on. One of the counties has a hospital which we can use, but also we're working out all the HIPAA and other requirements to put telehealth in the extension office, because that's often the hub for the community and a place that they can go and be comfortable. But that brings with it a lot of IRB things that we're working through. We're able to assess neuropsychological functioning over Zoom and provide that service. They want accredited tailored healthcare provider with continuing education. So we're working with that and trying to develop the workforce in these communities. It's interesting that students who have never been to a rural community will say, I like it here, I'd like to stay. And so that's one of our main forms of workforce development, is in placing graduates in these communities. Support is a lot needed with the caregiver. Tailored resource kits for the community, programming, support groups that we run in the community, adult daycare, and first responder training. The community education topics, we focus on prevention, knowing the signs of cognitive decline, what diagnosis looks like, but basing that on local resources. What we don't want to do is to provide a diagnosis and not be able to tell someone where they can get that support. Tailored education as well. So the evaluation of care, again, we're just in the start of this. So I still see the listening session as part of formative evaluation to get the messaging right. But we're hoping that we can increase access to resources so that fewer families are in crisis. The medium-term goal is to improve detection of Alzheimer's and related dementias. And then our long-term goal is to reduce the incidence of dementia diagnosis. The lessons learned in this project from the principles of community engagement, the first one is humility. One reason our communities work with us is weirdly not because we're experts. We are, and they appreciate that, but they come to us because we're humans first. And again, back to the personal. Lisa Renzi and Janae Beer, who are our director and co-director, their grandparents had dementia. And they tell a beautiful story of when Lisa's grandmother was in the final stages of dementia. She said, I don't know who you are, but I trust you. And so their promise to their grandmothers was to do something about dementia. So that passion is what drives them. But we go into this community, and before we engage in this kind of work, we realize that we are humans. So while we might not look at the same news, we might not have the same political standings, we are humans first. And all of that goes away when you're talking about something as important as health of their families. So it's also working with students and faculty who have preconceived notions about what the community is like. So it's that listening and the humility. We have talked about for a long time cultural competence, but that implies that we are competent in the culture, and we never are. So part of cultural humility is to understand we are lifelong learners, and we need to be open to hearing from people and understanding them. And then the third part is the honesty and managing expectations. We can't promise more than we can deliver. And the need is very great in rural Georgia. So we can only promise then what we will be able to do well. So let me conclude by saying that the challenge with community-based research are large. I should have also said one of my favorite things to do as a child, and I often wonder why my parents did not get help for me, but I had an imaginary classroom. So my grandfather brought home desks from the furniture that had something wrong with them. So I had a classroom of 20 imaginary people. And I came home and taught what I had learned at school. And each of those students had a particular, they had a name, and they had a particular, probably stereotypical description of them. There was Patty, who was very smart, but she wanted to be a beautician. And I would encourage her to go to college. And then there was Reggie, and he was going to play college football. He was a good-looking quarterback. And he was smart, but he didn't want people to think he was smart. So he did poorly on the test. So I had all of these, and I thought, well, that's what community-based research is. You are really managing expectations, and it takes a lot of time. So maybe that was part of my upbringing and training too. All these interdependent partnerships. In an academic setting, it is sometimes hard to justify the value of community-based research. Again, another personal story. So my husband does analysis of secondary data. So he's in his office, does that, great. So I come home and he said, what did you do today? And I said, well, I was at a school waiting to meet with the principal to talk about engaging their school in our study. And he said, that's all? That's all you did? It took you all day for that? Yeah, it does. It takes a lot of time. So the tenure clock, the promotion clock, it does take time. Navigating with the community, the external funding, the research protocols, gaining that trust, and making sure that we can deliver an evidence-based program and conducting evaluations. Again, it's been fairly easy, both here in Minnesota when I did my dissertation in conducting studies of alumni who had been gone from the university for quite a while, but our response rate was over 90%. Part of that is due to Karen Bernig and her survey shop at the time, but also to the fact that people are loyal to their land-grant universities. So I know that the ground beneath us is shaky at this time. We can talk about wars and mass shooting and the mistrust of public health and its institutions. So how do we move forward with community-based research? Because we have to engage communities if we want to improve the health of those communities. So in an ever-changing landscape, how do we move forward? And I think it's keeping our eye on that North Star. And the North Star is always for the prevention and promotion of health and disease prevention in all. So it is the public's health in public health, and keeping our strength and clarity on that. Our commitment to keep going no matter how hard it might be. We engage the public in these, we listen. If we don't understand the different political ideologies or why people believe what they believe, then we're destined to fail in this. We can't make progress if we don't understand. The path ahead is filled with challenges, but when has public health ever backed down from challenges? So how do we move forward? We have to move forward together, and that's in partnership with everyone who is interested in the public's health. I'm happy to take questions or comments.
say a little bit about the demographics in terms of rural Georgia? Is it, I'm gonna met Lux. And to be more elderly or older population, just a little bit in terms of that context.
Of course, the population is an older population. Once children leave, they don't always come back. And it's the leaving that is, some people don't leave. So we have a substance abuse problem, unhomed, unhoused. It is roughly, depending on the county and its agriculture, there can be a large Latino population, or it's about 50% Black and white. The income, I think with our counties, is below the poverty. I think the median income in most of the counties we're in is about $30,000. And you're seeing kind of the movement from small towns. So again, a health officer told me, and he was in the Atlanta area, and said we should just forget rural Georgia, because if you really want to move the needle, the population is in the metro area. But that's not how we do public health.
Hey, yeah, great talk. I'm curious if you guys have done any assessment around like community engagement metrics, especially with like the counties kind of feeling the top down. I wonder, getting their feedback on the relationship, whether they feel their voice is being prioritized, how they can be better prioritized, could go a long way. And if you guys have done any of that.
Yes, we do that with qualitative interviews. At the end of every year, I mean, it still is kind of an academic year calendar. And so we do that at the end of every year to talk about that. In one of the care communities, it's been difficult to engage lower income families. So we kind of notice who's not at the table and then work to get them there.
Question is, that getting funding for that listening part and establishing those relationships, what funding mechanisms have you found to fund that work?
They have been largely through R21s. And then for the CDC projects, we built those in, and that they will fund that part. For care, we are kind of putting together various funding for that, using some indirect cost funding, using some foundation funding, and then we can get Archway Partnership Communities. So that right now we're doing on our own, which also makes it good. Oh no, the hard
Oh,
question. I
No.
still have a little PTSD. Mr. Tricia.
No, we're always kind, and David Murray was always kind.
David,
As people know.
always.
No, one of the things you talked about here was sustainability. And you talked about the fellow in the county that says, where's my $250,000? When you start out with money like that and the project ends, then where are you with the next $250,000 or other things you do to sustain it without that external funding?
Well, that's why we still will have extension agents there. They will remain in the community. And the things that we're doing are more infrastructure changes. So, there's ownership of the community gardens. It's not us doing that. So again, it's hope that they will continue. The parks that we've done or the basketball courts we've renovated should be there for another 10, 20 years. But, it's a very good question. But we hope to not leave those communities because there's still a UGA presence there, and build a relationship such that we can still send students there for their internships.
The other question, Marcia, was, it's very impressive, the number of institutions and organizations you've been able to pull together, you know, how have you done that? Many of these are independent organizations that have their own agendas.
You mean like the Archery Partnership?
Right.
Well, that's a very good question. And I'm thinking of a story too. Adam was a runner. And so when we moved there,
Adam is their son.
yes, so he was in fourth grade. And he was running 5Ks. And he came home and he said, Mom, I met this man at the race. I think he does what you do. You need to meet him. Say, okay. So his name is Mel Garber, and Mel was also the face that I put with the care center. So it is about relationships, and it's just been working with those, and their agenda is our agenda. So that's what matches. The communities say health, and we bring health. And that has been sustained for 16 years. It's when I think that's what I was trying to say with the infrastructure. All of that is matching from the university president through the public service outreach units and, you know, through the individual colleges. So we're all, you know, moving forward together. And so we give them a good name and they give us a good name. And that's what's making it all work. At the end, we're just humans trying to do the right thing.
Keep trying. So thank you very much. Yeah.